Well, I just wanted to welcome everyone as well as our incredible speakers that we have here today for what is, I think, now the 12th or 13th session of Girl Up Edinburgh's webinar series entitled Exploring COVID-19's Intersectional Impact on Women and Girls Worldwide. So throughout the past seminars, we've heard incredible and insightful and meaningful conversations about, menstrual health, about forced genital mutilation, and now we have an incredible conversation about reproductive rights during COVID-19. And we are so lucky to be joined with these three wonderful speakers who will introduce themselves, and you'll get to know them shortly. Before we get started and delve into today's conversation, I just want to go through some housekeeping tips. So Girl Up will not tolerate any and all forms of hate, discrimination, or microaggressions. If you are engaging in this event in an inappropriate manner, then you will be kicked out of the event. Please mute yourself on arrival and remain muted. That said, we want to hear from you. So this is an interactive panel discussion. Use the chat feature to engage with our panelists. Ask questions and share your experiences. Please send any questions you have. The panelists are here to answer your questions and hear your thoughts. Just a reminder, this event is recorded, so feel free to show your lovely face if you feel comfortable using video, but if not, no pressures. And as always, please show the moderator and our speakers your utmost compassion and patience. So I really appreciate that from all of you today. So now we are going to jump into the introductions. So I'm going to hand it over to Sharon to just introduce herself and tell us a little bit about where she's coming from and what she's going to bring to this conversation.
I'm Sharon Esatoya. I'm Namana, member of the Comanche Nation of Oklahoma. Pardon me. And I've been the founding director and I am now the CEO of the Native American Community Board. Most of the women that we work with know us as the Native American Women's Health Education Resource Center. And we are based on the Yankton Sioux Reservation in southeastern South Dakota. We're a community-based organization, and we work with Indigenous people, women and families here in the US, but also a lot in Canada and Latin America, and we've also interacted with women in Africa and India. We work on violence against women. We have a shelter, transitional housing, men's re-education program. We have a food pantry. We do a lot of cultural preservation work. We have a clearinghouse where we develop a lot of reproductive justice materials because we do work in policy, a lot of emphasis on policy work, trying to impact the Indian Health Service, which is our primary healthcare provider. And our newest endeavor is KDKO 89.5 FM, a community-based radio station. And that's run for and by the community. And it's a great tool for educational purposes and getting out information, especially during a pandemic. Okay, we have been able to influence policy. And I just want to make it clear, when you do that on a reservation, because our system is federal, you not only impact the Indian Health Service on your reservation, but nationally. All reservations, including territories, Puerto Rico, Guam, etc., because they're all under Health and Human Services, and that's who we're under. Okay.
Thank you so much for sharing that, Sharon. I'm going to go to Janai.
Hello, everyone. My name is Janae Epps. I am the manager of special projects as well as the program director for our My Sister's Keeper program. Black Women's Health Imperative was established in 1983 on the campus of Spelman College in Atlanta, Georgia by Billy Avery. It was then at the time the National Black Women's Health Project. Billie Avery, who is our founder, she's still very much involved in the work that we do. She's an active board member and contributor to the organization. So we're happy to still have her here to work with us in the work that we're doing. So we're a national nonprofit organization dedicated to advancing the health, equity, and social justice for Black women through policy, advocacy, education, research, and leadership development. We do that by leveraging our assets. We implement a lifestyle change program, which is our branded program through the CDC's National Diabetes Prevention Program. We create messages. We were the first ever to publish the first ever comparative study for healthy Black women. We advocate, so we, released our policy agenda for Black Women's Vote. We're in the process of releasing our edited new version of it for 2020 for Black women, and just, how we can take back our political power during this time. And then we also try to reduce barriers, which is increasing enrollment of Black women into clinical research. So that's just kind of an overview of some of the things we do. And I did talk about one of our programs, but one of the other programs, the one that I am the program director for, is our My Sister's Keeper program, which is for college women on historically Black colleges, campuses and universities mainly, but then we do have chapters who are at majority institutions, in which the focus is on building the next generation of leaders in the Black reproductive justice space. And then we also have a pilot program that's happening in Atlanta, Georgia, with 2 high schools, which is our Sis Circles, Sisters Inspiring Sister Circle program, which we, build these young women to be resilient, health conscious, and leaders in their community, and that's at the high school level. So this is kind of just an overview of Black Women's Health Imperative and myself. Thank you.
Please tell Billie hello, give her a big hug for me, and ask her who I am, and have her tell you the story of how we got our center started. She was key in that.
Oh, wow.
Oh, how amazing. I'll definitely let her know. And then I'll circle back with you once I hear the story.
Yeah. Okay.
Well, I love how on these calls, we're all so far away from each other, but we're able to find these little connections, and even that's just beautiful to hear. So Leah, we'll pass it on to you.
Hey, hi everyone, my name's Leah. Wow, really hard act to follow with the last 2 people. I really can't wait to hear what you both have to say. So a bit about my background is I'm a PhD student in the Edinburgh Centre for Medical Anthropology at the University of Edinburgh. And my research is kind of broadly on reproductive health and reproductive rights. I'm looking at, I guess as we have quite an international audience here, I'll kind of give quite a broad overview, but some of you are probably aware that Ireland, the Republic of Ireland, updated its abortion laws back in 2018. They had a big campaign to repeal their constitutional ban on abortion, and they introduced a more liberal legislation, which has now been in place since the start of 2019. So I'm going to be doing fieldwork looking at that transition broadly. I was meant to be going and starting this September, but because of COVID, that is currently not happening so quickly. So I guess my perspective I'm going to be bringing to this conversation is kind of from the abortion rights area, and also broadly from the kind of the British and Irish context. I have quite a background in kind of the British pro-choice movement, which is very closely affiliated with the Irish pro-choice movement for reasons I'll probably expand on later. So yeah, I'm kind of going to be talking about what's been going on here kind of in academic and activist circles, mostly around abortion.
Great. Thank you so much to all of our speakers for that. And also to our audience here, feel free to introduce yourself, type in your name in the group chat feature, and tell us where you're from. We'd love to hear from you and to see where our audience is from. So now we're going to delve right in there. So reproductive rights, I mean, it's a term that has been common quite often recently and has increasingly come under attack. And we know that reproductive rights, yes, they are human rights, but what does reproductive rights really entail? And I mean, all of these questions are open to all of our panelists, so feel free to jump in whenever.
For Indigenous women, years ago, this is going back to when the National Black Women's Health Project started, the National Latina Women's Health Project started, the National Asian Women's Health Project, and the Native American Women's Health Education Resource Center got started. We all worked together because it seemed that mainstream America was one issue, and that was abortion. And it was either you were, pro-choice or not. And we as Indigenous women had to define what our definition of pro-choice is. Because reproductive justice is so much different than just one issue for Indigenous women. So we came together and we developed a reproductive rights agenda for Indigenous women. And it goes from everything, and it includes housing, the right to education, the right to self-identify, just so many rights. There's like about 25, 30 points. And about every 10 years we come back together and we update it and we add things that, in fact, we just finished the third go round. But so for us, it was looking at expanding the definition of pro-choice, because in as much as you may not decide that that's what you would do in a certain situation, you still, for us to be pro-choice, it would be to make sure that you respect the right of another woman to make the decision for herself, even though it may be different than what you would decide for yourself. So that allowed for a lot of space for Indigenous women to participate. And it wasn't so black and white, so red and white, so yellow and white. It was inclusive. And we've done that ever since. And it's amazing. There is a place at the table for just about every Indigenous woman, not all, but of course there are those that are a hard line anti-choice. But so it's worked out for us very well in terms of, creating spaces for women to that are very marginalized to have a place at the table and consider themselves pro-choice.
Mm-hmm. Well, I mean, you already brought up a crucial element of this conversation, which is reproductive justice and how, tackling reproductive rights from kind of a holistic approach and all of these other elements that intersect and are important. So I was wondering to our other panelists, if you just wanted to expand on that, maybe talk a little bit about what makes reproductive justice different from reproductive rights advocacy, or is it the same thing? Or...
So I like to answer that. And so from the Black Women's Health Imperative perspective, when you think of reproductive rights, it's like, if we have those rights, what happens when we can't access those rights? What happens when, there are barriers put in our place? So that's where the reproductive justice piece comes from, where we are intersecting the social justice movement. So making sure that we have the social and political power to not only access these services, but to speak up if those services, if our rights are being impacted and we're not able to obtain those services. So for the Black Women's Health Imperative, we look at the intersectionality of it and how our lived experiences of Black women impacts our trajectory through access and reproductive health services, and how we continue to advocate for our rights to have that access. And I think when we look at the intersectionality of it, we're looking at all of those things, like what Sharon mentioned, the housing piece. We're looking at community justice and safety, because if we are thinking about our overall being, what is impacting us around us? What are the structures that are in place? What is it like? What are the the discriminatory practices that are happening, that are impacting us when we walk through that door to receive those services. And so we're, trying to make sure that we are tackling this in every area and making sure we are accounting for all of those intersections. So the social equity and justice piece, even other chronic conditions that intersect with our reproductive health access. So, that's just kind of like the overall for Black Women's Health Imperative and how we continue to, translate the research, how we continue to create the messaging for Black women. I mean, Black people are not monolithic, so of course we know that, but then looking at the intersectionality and looking at the lived experiences and honoring those as we continue to do the work, I think that's, how we've been moving within the reproductive justice space to make it more inclusive and reflect the intersectionality and lived experiences of Black women.
Leigh, is there anything you want to add to that?
Yeah, sure. Yeah, I always think with reproductive rights, it's interesting because they're quite new. Like we're so naturalized in the way we talk, like you kind of assume they're just this phrase, this concept has been around forever, but it's really a relatively recent development. And it's been a very effective political tool in a lot of ways to advocate for change. But we do also see limitations with this kind of rights-based framework. So for example, you get this idea of dueling rights, fetal rights being pitted against women's rights, or people's right to healthcare being pitted against someone's right to object as a conscientious objector. So kind of end up getting in these tangles of rights-based arguments. And we also see the kind of vernacularization of rights, which is where a right kind of gets created at the global level by, the UN or something, but then how it actually gets translated and implemented and understood and practiced on the local level can vary a lot. And it can sometimes have kind of contradictory or unexpected or paradoxical effects. So, I think we owe a real debt of gratitude to the feminists in the US who developed the reproductive justice framework, because it is this very holistic way of thinking about it and approaching it. And I think it opens up a lot more room for discussion. So obviously here in kind of mainland Britain, we've had abortion has been a right, it's been legal since 1967. But that doesn't mean everyone can always get it all the time. And then if you actually think about it, from a broader kind of reproductive justice perspective, you start thinking about all these intersecting issues, such as, we have a 2-child limit on child tax credits. You don't get tax credits for children beyond the second one. So, it's not just people's right to access abortion care, it's people's right to actually have as many children, and how it intersects with their economic and social conditions. So it's a very useful framework for expanding that question and including a lot more positions, I think.
Well,
right.
Yeah, would you like to add anything on?
Yeah, I did. I would. All these intersectionalities are so important because for a long time it it was very difficult to get to build intersectionality within movements such as the environmental movement and violence against women. To get them to understand or to see that those are reproductive justice issues as well. We've worked on policy issues within the Indian Health Service, and so we said, okay, violence against women is against the law. And so we want to make sure that when you go into an Indian Health Service emergency room after a sexual assault, after a rape, very violent act, that you have standardized sexual assault policies and protocols in place. Also, when you're looking at environmental issues, all these herbicides and pesticides and chemical push farming, we're looking at birth defects, we're looking at various cancers and things. And so you've got to be able to see how things intersect and interact with one another. And like I said, it broadens your whole thinking about what reproductive justice is. All of the harvesting for natural resources that take place in indigenous lands, and how does that affect our reproductive health? I mean, both men and women, okay? the uranium tailings that are left behind, the toxicity from gold mining and oil companies and so on. It has a very profound impact on our reproductive health. So we include those issues a lot. And in terms of coalition building, that just gives us that much more participation and gets people, there when we need them at certain events and activities, and advocating and lobbying for the same thing. But those are really important issues, and are encapsulated and are included in our reproductive justice issues.
I'm so glad that the intersectional lens is joining this conversation very early. I mean, it's a crucial one. And I mean, intersectionality, as you all have mentioned, has been a great tool for coalition building, and, also the lens to use to see, how intersections and how systems and hierarchies of oppression can exacerbate a situation. And one of those is kind of the reproductive health issues. And so reproductive health issues and the healthcare system has, consistently failed women, specifically, Black and brown women and Indigenous women. So I was wondering if we could talk a little bit about what reproductive health and issues look like, in each of our communities, but also, what the historical relationship between state violence and reproductive health, and kind of, the context of, what health issues are pertinent in communities, and how has reproductive health really been weaponized by the state or by oppressors in the past, and is that still continuing? I know this is kind of a big question, so take us down.
Yes, it is continuing. We've gone through the sterilization abuses that were done by the government, in government agencies, within the Indian Health Service, which is a government agency. And they sterilized a lot of our women without knowing. And they would go in for an appendectomy and come out and they would be sterile. I mean, there was just a whole lot of, there was a movie, in fact, a British filmmaker, Lorna Tucker, made the film, and it's called Ama, and it came out a year before last. And it's about the sterilization abuses that took place within Indian country here in the United States. And I was an executive producer on the show, or on the film, so I was able to make it over to London for the grand opening and so on. But it's a documentary, and I really recommend seeing it because it's very accurate, and it gives the history of the sterilization abuses, and it even interviews survivors and so on. But so we've had that. Okay, then we fast forward it, and we're looking at Depo-Provera and the atrocities that happened within communities of color and Indigenous communities, and how it was administered, and then Norplant and its refusal to remove it on demand. Okay, and some states saying, oh no, we can't remove it because for reverse of intent, even though you may have put on 20 pounds in a month or two, or you're having high blood pressure, or all kinds of contraindications that make it very bad choice for you. So the state, if they put it in with state dollars, they're saying, no, we have the right to say you can't have it removed. So there's all these markers that, if you look at them historically, that have taken place from way back to current, and so now we're looking at Indian Health Service, and they don't really offer a wide selection of contraceptives such as other women. Now we're the organization that worked hard and got Indian Health Service to approve Plan B, emergency contraceptive, when everybody else had it in their systems, and every state it was legally, it was federally approved, and Indian Health Service would not provide it. So we worked real hard, and we got that, you know, in as a policy that they would provide it on demand. And so there's all kinds of things that happen within our system that can be kind of tucked away, and the mainstream not aware that it's been going on until the women start advocating and standing up and shouting from the rooftops. And then change will happen, even though change has occurred in the mainstream already. So there's just a lot of instances of that kind of abuse, where the federal government has really abused us in terms of sterilization, and whether it was intermittent or permanent sterilization.
Yeah, so I just wanted to follow up on that, Sharon, for what you said, especially about the sterilization piece, because another documentary I had a chance to watch was, which is Belly of the Beast, which was created by Erica Cohn, and I had a chance to moderate a panel with them, and you know, they talked about the forced sterilization of women of color within who were incarcerated, specifically the California State Prison, in which, you know, these women were, you know, they were coerced into consent. So it was like, you know, rushing them to fill out the forms. They didn't get a chance to really read it. Of course, these are women who are incarcerated. So, you know, where else can they get their, you know, services from? And, you know, just the interaction that happens between that physician and that woman during that time. And, you know, you may go in and say that you have cramps, and they may say, oh, you know, have cervical cancer, you know, let's give you a hysterectomy. But then when the woman, and I'm speaking of the woman who was really featured in that documentary, who, when she came, when she was released from prison, she found out that she never had cervical cancer. And so it had happened for more women during that time. And I think it was about 20,000 sterilizations that were done from early 1907 or something like that, all the way up to, they even had some that were still being done illegally up until 2013. And so there are women of color who are walking around who don't even know that they have been sterilized. Because it's like, if you don't have that knowledge before you go in, how can you confirm that? And then the issues about being able to access, you know, medical records and things like that. So that's another way of how it has seeped into not only just the indigenous community, but then also into the other Black and brown communities as well. But then also when you think about the experience of the Black woman, we go all the way back to slavery, when the father of gynecology, when he did these procedures on enslaved women, and just how that fostered the creation of these modern tools and things like that, and what we see in reproductive health to this day. But then also just the violence that was done against women, you know, not being able to protect themselves, not having the laws to protect them when they were forcefully abused and sexually assaulted. There was no rights for them during that time. But then also fast forwarding to the Black maternal health crises right now, you know, of Black women being scared to give birth because of a doctor not listening to them and losing their lives while trying to bring another life into the community. So we think about all the years and how things have been exacerbated because it's nothing new. But these systems that are in place are what perpetuate it. And that's why, you know, you have women who are advocates to speak up for those things, because what has happened in the past is still happening now. And I think we're still bringing it to the forefront, where we talk about implicit bias. And, you know, that's nothing new, but, you know, everyone thinks like, oh, and now racism is being, you know, deemed a public health issue. I feel like I'm going on the rant, but all of this is, you know, leading up to what we have now, where the histories of our lives are still playing out to this day, and how we have to constantly keep fighting for what is owed to us and what we deserve to be at our optimal health in this world. So it goes on and on.
Yeah, it does.
Yeah, Leia, I was wondering if you could join this conversation, maybe bring in some elements of, what the Irish experience looks like and how kind of, religion has played into like the system and state violence.
I mean, yeah, historically in Ireland, so when the Free State declared kind of independent as a republic from British rule in 1922, because of the former British colonialism by like the Protestant British powers, the new Irish state very much forged around this identity of kind of Irish Catholicism. So from the very start, the church and the state were incredibly interlinked in the Irish context. And the church were really in charge of providing a lot of the social and medical infrastructures that usually you'd associate a state with. So like the schooling, the hospitals, they were all run by the church. So basically you just saw this moral monopoly where women, contraception was illegal in Ireland until I think 1985. Divorce was illegal until I think 1995. And abortion, as we know, until 2018. So you really got, the impact of that kind of ethos was felt at every level for sure and really shaped the infrastructures. Mm-hmm. And I think as well, like in Britain, there's very kind of feeding on, tying into what the others were saying, like we were very complicit in the creation of a lot of these regimes around the world, forced sterilization, so many things that the British colonial powers did. And we get very little education about that over here. Like, I feel like we're all very unaware. And that's something that people are beginning to talk about a lot more, kind of with the latest Black Lives Matters conversations and the toppling of statues in Bristol and things. But there's a lot more work that could be done. Like we know very little about what we're not taught it in schools.
Can I say something, Cheryl?
Yeah, go.
I'm just joking. Sorry, I popped in late. That is somewhat true in some of the countries that I work in Africa because of colonialism and the way the governments were set up and the culture, and the formalized religion and languages still are reminiscent of colonial powers. But it's also, it's a global situation. Like, we need a global movement at all times, whether it's Indigenous women in the United States or, African women in Uganda or Kenya that are experiencing some of the same things. We have this global gag rule that's batted around like, a political issue when it actually affects millions of women's lives globally, right? And you get a Democratic president that, lifts the ban the first day in office. You get a Republican president that puts the ban in place first day in office. And it really does highlight the politicization of women's bodies. And I think that's something that we always have to be like super mindful of and always organizing around and trying to make these relationships globally to empower each other and support each other, whether it's Ireland or Uganda or an Indigenous population or Native community somewhere. It's like women are always, their bodies are always politicized by those in power. And you do see changes and you do see women organizing and you do see forward movement for sure. And as women have more positions in leadership in parliaments around the world, and I can speak like in Africa, there's been such a great forward movement to include women in set-asides and quotas and empowering them to run for office, that you really do have really great outcomes. And the conversations do start to change, although it's still really slowly. But like right now, one of the big issues in many of the parliaments in Africa where women are leading is divorce, right? And child custody issues. Hasn't totally gotten to abortion or reproductive health care, but where I'm seeing changes in those areas is in the informal sector. So a lot of the women that I work with in the informal sector are have set up shops, or whether it's in their homes or a more a little store in the community, and they have birth control in their shops, and they become like the leaders in the community and the facilitators and the educators, right? But it's quiet and it's very under the radar. But women can access pills and different forms of birth control locally for very inexpensively, not if you live on less than $2 a day, nothing is affordable, but you know, it is relatively inexpensive. You don't need to see a doctor. And so it's kind of interesting to see what's happening in the informal sector in many parts of the world with reproductive healthcare and birth control outside of this formal sector that we kind of function in.
Yeah, well, thank you so much, Karen, for bringing that to the conversation. I mean, it's super important, as you know, we've been talking about kind of like institutional and kind of these formal barriers, you know, legislation and policies such as the gag rule, systemic racism, and, you know, class and economic insecurity. So I was wondering if we could go towards more of these informal barriers, you know, stigma, social behaviors, but also how, you know, a lot histories of oppression and abuse kind of result and breed a lot of distrust in the system. So I was wondering if we could talk a little bit about the informal barriers that women and girls face when exercising their reproductive rights in the context of how, you know, these informal barriers will change during COVID-19, which we'll get into right after.
I'm just going to say one word and then that's it: poverty. Poverty and lack of resources is really I think is the number one driver of women not being able to access full reproductive health care, because then it goes into education because they're under-resourced, right? So it's like poverty is the driver of so many social ills and so many inequalities for women and girls.
Well, that's interesting, you know, that you would say that, because, you know, lack of resources is key. We just don't have things that a lot of people take for granted in the mainstream, just communication. We still have homes where people don't have telephones. They don't have a cell phone. Of course, they don't have internet. So they're really out of the loop. Especially with you know, pandemic going on, where some schools are you know, teleconferencing and so on. It isn't happening in a lot of communities because of the lack of those resources. We've got women who don't have automobiles and have to really do a lot of arranging to get into town to see their healthcare provider, especially out on the reservations where, you know, town might be, you know, 75 miles away. So if you're trying to run a race against time, because you may need the morning after pill, emergency contraceptive, or trying to get in to see an abortion, you know, an appointment with the abortion doctor. South Dakota has one clinic in the whole state, and it's very, very busy. So timing is of the essence. So these kinds of, you know, really just day-to-day operational things present a lot of challenges for a lot of women, and you know, the mainstream just kind of take it for granted. Rural women in general, and then you know, you can break it out into African American communities, Appalachia communities, but reservations, and that's you know, you're getting pretty rural on some reservations. So yeah, ruralization and the lack of resources is a huge issue.
And I would just echo that.
Yeah, Leah, or Janae, anything else you want to add to this? Talking about informal barriers, stigma, trust.
So everything that was said, you know, especially when you get to the breakdown between urban, suburban communities versus rural communities, you know, we see that through our programming with women. You know, it was, you know, even we think about the COVID-19 response, you know, it was things that were happening that we knew of in DC and, you know, Maryland, but then some of our partners down in Alabama didn't quite get the information yet. So that, you know, even how emergencies are communicated, you know, it's exacerbated now because those were issues that had happened before. And then also, you know, the lack of investment But even where there are services that can be accessed by communities of color, some of those other, the distrust, for providers, that implicit bias, not feeling like, not being satisfied with your care, some of those things will turn someone away from even accessing services that are right in their backyard. And I think that is very key, when we think about the LGBTQ community, especially the trans population, how they have to educate their providers, So if I have to, every time that I have to go and seek service and I have to educate someone, I might not be in the space to do that, or, delaying services because of that interaction. And so I think those are some of the other things. I mean, of course, couple that with lack of resources and things like that, but just, not feeling safe mentally, physically, emotionally, to even go into those spaces, I think is some of the unheard kind of things that really propel someone to go access some services. It's like, how do I feel? If I'm not feeling well to go do that, I'm going to delay it. And I think that's some of the things that we're seeing too.
Yeah, I want to add, like, rural is also a big problem in the UK and Ireland as well. Like in Ireland at the moment, so they introduced abortion services. There are still a lot of areas where there just are not. So it's an opt-in service for providers, doctors. It's being provided through GPs or through hospitals. By the end of its first year of running, something like 15% of GPs were signed up to provide it, which means, a lot weren't. And then County Sligo, 80,000 people, rural county, pretty big, hard to get around if you don't have a car. They have no GPs, no hospitals providing it. So, and that's still the case now. So those women or pregnant people who don't want to be pregnant are having to travel pretty far distances to get to someone who will give them the care they're wanting. Okay, they don't have to travel to England anymore, but it's still a barrier for some people. And it's interesting, actually, because they did women on web who provide kind of abortion telemedicine to areas where it's not legally available. They published a study about people who were requesting pills from Britain, where they should, pretty accessible generally, you'd think. Why would people be requesting it from an online service? And it was the most marginalized people. So it was people who wanted to conceal their pregnancy, who were concerned about the privacy or the stigma. It was people who just could not get to a clinic or a hospital because of childcare issues. Domestic violence was a very big factor, not feeling safe to actually go out and seek their care outside the home. So it's kind of, you just perpetuate again. It's always the most, marginalized people. People who weren't aware that they could access NHS care for free or were not eligible for free NHS care. That was another one, couldn't afford it privately. So I think it's the same story being told over and over again, isn't it?
Yeah, I mean, these common themes of lack of resources, but also transportation. And I mean, Janae, when you bring up like investment, that's such an important aspect when we're talking about technology, even, ending the digital divide that Sharon brought up, that is so prominent in all federal lands, including, military bases, but also our Native American reservations. So I guess kind of to turn to COVID-19, I mean, we've talked about this already a bit about how transportation is even more difficult in terms of what's available, what's open. Economic desperation has increased. We're seeing contraception shortages. So I was wondering if you haven't already, you've already mentioned kind of extensive, amount of ways that COVID-19 could and has exacerbated this situation of accessing reproductive health. But I was wondering, talking about reproductive health, family planning, community health services, how has that changed? What's the significance of inessential versus non-essential, and kind of like these logistical barriers that, the everyday woman and girl is facing during COVID-19?
I would just say everyone is stressed. Everyone is stressed from, everyday folks to professionals. Everyone is stressed, to the kids who have to learn, digitally. Everyone is stressed, and we cannot ignore what chronic stress does to the life of someone. And, you know, when we think about chronic stress and what that does, it exacerbates other health conditions, right? You know, heart disease, type 2 diabetes, things that put you at higher risk for contracting COVID-19. So when we think of all of that and just that emotional wellness piece, and then the lack of mental health resources to support people during this time, I think that has been one of the biggest things that we've seen and heard. People are stressed. They're stressed about how they're going to provide. You know, when you get into the menstrual equity space, you know, someone having to choose between, you know, products for something that's a normal bodily function, versus, you know, getting food for their family. You're talking about wages. You're talking about Black women leading households, and they also have to work, but then they also have to come home and be the teacher, or the fear of going out to do essential work, and coming home and impacting your family, not having enough resources to say, oh, if someone in our family contracts COVID, they can go stay with this person. It's not like that for everyone. So when we think about it as a whole, everyone's stressed. You know, it's so many things that we can do, but if you think about someone who is chronically stressed, the decision-making process, you know, they just don't have the mental and social support that's needed during this time. And I think that is what we've seen and what has impacted all of these other conditions that we already know of, and how it always exacerbates what has happened. People are stressed.
That's putting it really good. Yeah, also the political aspect of it. You know, South Dakota, I mean, you know, hey, Kristi Noem is our governor. And I mean, she's like, you know, not very bright. So she says no masks. They allow a Sturgis bike rally to take place, you know, 450,000 people coming into a town that only has 7,000 population year round. Can you imagine? It's like, you know, being a grain of sand out on the beach, you know, everybody's just crammed together. And so now, you know, the cases of COVID have escalated, and, you know, and she's not saying anything about it. So the politics behind this, and of course, our current president and his bizarre level of intelligence when it comes to scientific evidence and information, you know, that's really exacerbated. And then you look at his racism, and you look at what communities are getting services and what communities are not getting services, and who's getting tested, who isn't getting tested. You know, it's just, I'm not one to believe in conspiracy, but, you know, to me, it's being used as a weapon until after the election, because a lot of people that aren't going to support him are people of color, people low income. And so, hey, you know, he sees it as, let's don't do anything for that population. And that just knocks off some voters. I mean, that's how I'm beginning to feel. I've been feeling this way for a while. So it's a very dangerous time. It's a very dangerous time. And it is being used as a weapon. And if you can't access your health care and you are dealing with this pandemic, you know, we have people who have COVID, and they get shipped up to Sioux Falls, which is about 130 miles away, and they don't put them in the hospital, they put them in a hotel. And then a health worker comes around and checks on them once or twice a day. That's crazy, you know. But if they are not from the reservation, they're going to get put in the hospital, no questions asked. There's just a lot of things that when this is all over and done with, I think there'll be a number of investigations, and they're going to find some things out that are just beyond understanding how another human could do something like that to another human being. A bunch of atrocities. And it's based on race, income, zip code. And that's, you know, really weaponizing this pandemic. And it's just been extremely challenging to provide services during these times. You've got domestic violence, you know, and that's escalating. And you've got law enforcement that don't want to transport people in their vehicles, so they don't come to calls. You know, it's just such a state of chaos, and it's affecting everyone from the children to the elders and everyone in between. Yeah, and safety is a huge issue. Yeah.
Yeah,
So
it's interesting, you know, how you're bringing up it's weaponized. And, you know, at the beginning of this conversation, we talked about, you know, how reproductive health and services were also weaponized. So, you know, these relationships just keep on coming. Sorry, Leah, would you like to expand?
Yeah, I mean, it's been, in terms of like the impact of COVID on reproductive health and access to services and things, it's been quite a mixed bag in the UK, I'd say. Like, there have been some positives have weirdly come out of it. Because I'm thinking I went to a panel last week that was about basically, so in Ireland and the UK actually, not Northern Ireland, but England, Scotland, Wales, they quite quickly introduced telemedicine abortion. They introduced a temporary change to the legislation so that people could basically have a phone consultation and then be sent the pills by courier and have that home. So beforehand, that wasn't an option. You had to go into a clinic. And the majority of terminations are carried out medically in the first trimester anyway, so that does account for the majority of service users. And apparently, like, that's actually gone incredibly well. Like, wait times are down. They're seeing people about a week or two earlier gestation than they were. Like, the people who are providing the service in the UK are like really happy about it. They say the feedback they've had, like, it's all very early, but they say the patients are liking it, the providers are liking it. It's actually like really helped them streamline things a bit. So it's nice to hear some bit of good news from, you know, you kind of expect everything to be negative, but they're really hoping they can, in the UK, they're really hoping they can change this legislation and kind of keep it long term, because it would be useful. And Ireland did the same. Ireland changed it to allow telemedicine abortion, which has actually really helped these people in places like Sligo who were having to travel long distances before. So that's, you know, one positive that's come out of it. Northern Ireland has not got this yet. And basically there was a bit of a mess because so they decriminalized abortion during, like, in the first week of lockdown. That had been due to happen anyway, and that's just when the new law change came into effect. But basically, you've got a very anti-abortion people in charge. So they didn't actually commission any new services. It just became decriminalized, but they never got around to actually, like, telling any of the health services to start providing the service. So then they told people, oh, well, there's a lockdown, so you should probably just keep going to England, which people don't really want to do when there's a lockdown and you're not, like, none of the travel is running. I think there were like freight ferries going between Northern Ireland and England. So obviously that was not a great system. So basically, as far as I can tell, I think some of the health commissions in Northern Ireland have just begun to provide services off their own back because it's legal now, but they haven't been told to. And also, like, I think there's been quite a lot of like informal provision with like women on web and things. But yeah, obviously, like, that's, you know, if you're looking outside abortion, like, obviously we're seeing high rates of unintended pregnancy, high rates of kind of reproductive coercion, domestic violence has been massively increased because of people being stuck at home all through the lockdown. Unemployment obviously going to keep rising. So I'm sure there's going to be a lot of people who are not going to be able to build the families they want because of the direct economic impact of this. I'm sure rising rates of period poverty, like everything. And then as well, like, births and people who have been pregnant or had children during the lockdown. It's been a very stressful time because people have been nervous to go into a clinic to actually, have checkups. And there were cases early on of people being told their partner or a birthing partner couldn't come in with them, and so having to give birth alone. And I know a few of my friends have had babies in lockdown, and they were just pregnant before it started. And for some of them, it's been quite a nice experience in a way because they were furloughed or working from home anyway. So you more time alone with the baby. That part some of them have actually quite enjoyed that. But very different situation if you're an essential worker who's still having to go in and work as a frontline service operator. It would be a totally different experience in that case. So yeah, it's impacting so many people in so many different ways. It's kind of hard to even comprehend how that's going to happen over the next few years and the long-term effects.
Yeah, and I mean, I love how, we're able to have kind of a comparative, analysis of reproductive health and, the impact of COVID through kind of this panel session. Marina, our vice president, actually wrote something in the chat that I resonated with very much. She goes, I remembered learning about telemedicine abortion as an option and was pleasantly shocked that this is something that a government would consider. As an American living in Scotland, it's always indescribably surprising for me to see what access to reproductive care is like here. And I mean that with how they've ended period poverty in Scotland and New Zealand. I mean, we're really seeing how policies can change depending on who you not only have in power, but also, the values of, your own community and of the world and, the country that you live in, for better or worse. So kind of a lot of the chat that we've seen ongoing throughout this conversation, a lot of our listeners have been talking about sex education in their schools and what they've learned. So I just kind of to wrap it up, we have a question from Antonia, and she's from Chile. I don't know if she wants to give a little hi or take her camera off, but we'll see. Antonia goes, in Chile, oh, there she is. Hey, do you want to ask your question? Okay, great. She goes, in Chile, in terms of reproductive rights, we are very behind. Abortion is not legal and sexual education does not exist in our schools. So I want to ask you, that women, we are constantly creating spaces to fight for our rights. What must we do to be able to change our society, especially in Latin America? What do you recommend to start making changes? I really want to do more things here in Chile and be able to help. I mean, I couldn't think of a better audience to answer this question with these three incredible speakers, and Sharon here, who's, feminist celebrity. So this is, great. So have our panelists, how would you respond? What can we do?
Here in the US, it goes state by state, and it may be, legal, but you have to have the service. And like I said, South Dakota has one provider, and South Dakota geographically is a very large state. So, women are still having bake sales and pitching in and donating money to other women so that they can, if they live on the other end of the state, travel to out of state to receive those services. And if you're in a country that does not have those services at all, if they're illegal, I don't know, do women cross the border and go into a neighboring country where it is legal? And what hoops do you have to jump through in order to organize that kind of, and bring in those kinds of resources so a sister can access an abortion? That's one question. And then the other one is just a statement. Indigenous women have always had, we had our traditions and our medicines that allowed us to, we had the knowledge to be able to determine if we were to have children or not to have children. And we knew those techniques, we knew the herbs to take, and some reservation communities, very rural ones, that those things are still practiced. And so I don't know if they are practiced in your country or not, maybe in the rural areas. But to hook up with the women that still have that traditional knowledge is very important, very important. Okay.
Yeah, I'd just like to add to that, like, I'm not an expert on Chile by any means, but if there are already groups that are doing stuff, like, you don't need to start from the ground up, like join the people who are already working on this and kind of related issues. Oh, sorry, my cat is pushing the laptop. Holly. Okay. And like abortion funds as well, if those exist where you are, they're very worth donating to. In the UK, you have the Abortion Support Network, and they provide funding for women who have to travel to Britain for abortions from either from Ireland or Poland or Malta. And I think there are probably going to be similar ones in Latin America. So those are a really valuable fund for kind of as a stopgap until we can change things more widely.
And I would just say, we say organize, 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 but also finding other like-minded folks who want to see change, and you can use your collective power to make change. I'm not an expert of Tilly either, but when we think of comprehensive sex education here in the United States, we still don't have comprehensive sex education. I remember when I was going through the public school system here, we didn't have comprehensive sex education. I didn't get comprehensive sex education until I went to college, and I had health education as my major, and so I kind of had that knowledge. I had to go get it myself, but then that's why I also do give back. And I think when you find other women who believe in what you believe in, and you all think that you can make a change, I think it's always going to be power in numbers. And power in numbers, and this is not something that happens overnight. When we think about the reproductive justice movement, there is some cross-generational conversations that have to happen, because we do have legends like Sharon and Billie Avery who are still around, and then you have young women who are coming, and then either younger women, so the millennials, you have the Gen Z, who have a different approach to how we want to address this, but that shared knowledge is always going to be important. So, going to the elders and seeing what shared knowledge can you guys put in your, add to your toolbox to go on and, collectively educate your peers, but then also the generation that's coming behind you. So I think, with everything that's going on, is always going to be cross-generational, and we have enough information from all of our walks of life to contribute and to make change as a whole. So, that would just be my suggestion.
Well, this has been incredible. I can't understate that. This has just been absolutely amazing. And I want to thank you all panelists for joining this session, and for contributing and sharing the real life experiences that your communities are facing and countries across the world are dealing with before COVID-19 and after. So I just want to thank our panelists again, as well as all of our attendees for joining this session. The webinar series continues. We have our final session on the 28th with Karen Sugar, who's on this call if you want to give a wave. And in that session, it's going to be more of an interactive discussion, and will be about, stigma, as we're going to also be talking about sexual and reproductive health and stigma and who it benefits. And then talking about wrapping up our whole series from a global perspective. So this will be really great. Join us there, and we'll see you all on Friday. And thank you again to Sharon, Leah, and Janae.
Thank you.
Thank you very much.
Bye. Have a good day.
You too.